Thank you for that very generous introduction, Gavin. And it gives me a great pleasure to be here. Focusing on the next generation of global health leaders is a real priority for me personally and for IntraHealth for a lot of reasons, because our origins are actually at UNC. We used to be a program of UNC a number of years ago, and 13 years ago decided to spin off just so that we can be more impactful, we can be in more places, we could do more things. So, as Gavin said in his introduction, my presentation today is going to focus on the human side of health systems. As we speak, the African Union is actually meeting in Addis Ababa, and this is the first time they're actually having a meeting on the subject of leadership, and a lot of it has to do with health leadership. As a matter of fact, there is an extra day or an extra session that IntraHealth will be co-sponsoring with others, organized by the Africa Health Business Africa. It's the Africa Healthcare Foundation is really a consortium of African entrepreneurs who are really taking a very active role in contributing to health and making sure that the private sector does its part. And so when they invited us to join, we just said, my God, what an opportunity. Because almost 20 years ago, the African heads of states came together in something called the Abuja Declaration, where they made a pledge to invest 15% of their budget in health. As of today, unfortunately, we don't even have a handful of countries that have met their objectives. I think there are 3 or 4 that are actually spending 15% of their budget, which clearly is a necessary investment if we have to do the work that remains to be done. And it depends on where you're looking at it. If you're looking at it from, and I will use the Lancet Global Health 2035.
I did not ask Pop to say that.
Because Gavin was one of the commissioners. And if you believe that report, which talks about a period soon where we're going to reach this grand convergence, and then of course we're going to have to deal with new set of problems like non-communicable diseases and so forth. He will agree with me that investing in health will make a lot of sense. And I think it's hopeful, certainly for sub-Saharan Africa, because today people can hear the conversation. When you start talking about economic growth, it means something to people because they're seeing it. If you travel around Africa these days, you will see that in many major capitals, there is really movement. Things are happening, there's growth, that's why I think the conditions today are much more favorable about really being heard by these decision makers. So it's a great opportunity to continue the advocacy about why we should invest in health in general, and more specifically, why we should invest in the human side of health systems. Because without the people, that is very true, there's very little we can do. So I'll share in my about 40 minutes or so just this presentation, which is, as it says, this idea of solid investment in the health workforce crisis. It was only in 2006, not long ago, that World Health Organization dedicated their World Health Report on the subject of the deficit of healthcare workers. Until then, the community remained pretty silent on the subject. I think the Rockefeller Foundation, the World Bank, and some other organizations sponsored this big study, which showed that in fact there was crisis. And 2006 was when the alarm bell was rang, and we said we have to do something about this. At the time, we actually thought that the crisis was much more manageable. As you will see in this presentation, it's still very severe, and it's not getting better, unfortunately, which is a sign that maybe we're not doing things right. So it is entitled investing in health. This is what we believe in at IntraHealth. We do believe that everyone, everywhere should have the health care they need to thrive. And I want to underline to thrive, because it is important to talk about that. It's no longer just health being the absence of disease. I think that's the whole idea about a period of the grand convergence and all that is because we are investing in health, we are really reaping the full benefit of investment in health. And that is really what's going to drive people to contribute to the economic development and to thrive themselves. So we want populations that are not only free of diseases, but are healthy and remain healthy so that they can contribute. When you know the ravage that, like malaria, for example, it takes people out of work, it really saps their productivity, and there's billions and billions dollars that are lost every day because of lack of productivity due to sickness associated with malaria. Okay, so anyway, IntraHealth believe that we should have the health, everybody should have the health care they need to thrive. Our mission then is to improve the performance of health workers and to strengthen the system in which they work. So like many other organizations and institutions, we focus on health system. At IntraHealth, we see everything through the lens of the health workers because, again, we believe that they are the one who are the link with communities, they are the one with the link with the health system. And I think focusing on those health workers is just extremely important. And by the way, it's not just about the numbers neither. Unfortunately, people tend to focus mostly on the numbers. We're lacking 7 million. When we factor in the SDG, we're really lacking about 18 million health workers, professional health workers. But we have to, at IntraHealth, we do have a holistic approach of looking at this. We're looking at health workers who are present, ready, connected, and safe. Present, basically, they are present where they are needed the most. And as you know, both in low-income countries and high-income countries, we don't do a good job at making sure of the distribution, making sure that health workers are where they need it the most. In this country, there is a shortage of doctors in the most remote areas, and the same is certainly true, and the crisis is more severe. So they need to be present and well distributed. They need to be ready in terms of just have the right preparation, the right training, the right tools. They need to be connected, and it has actually double meaning these days. They need to be connected to the system in which they work and they manage. They need to also be digitally connected because the health worker of the future, if they're not digitally connected, they're just not going to be able to do their work. They're not going to be relevant anymore. And they need to be safe. And we need to emphasize this because not only do we have a severe shortage of health workers, but we are losing health workers to violence, unfortunately. There is people in some parts of the world, people engage in this very bad practice of attacking health workers and attacking health facilities, and that is really too bad. So in our advocacy, we also need to insist that these workers, and plus the fact that the health workforce is 70% feminized. So you have a majority of female workers who are subject to all sorts of difficult conditions, work conditions. So really you have to look at beyond the numbers and make sure that they have, they are people, after all. They're people with needs that we really need to work hard to meet. So just a few of our results that you can see. This is straight from last year's report, I believe. I should probably take the opportunity to thank my colleague, Gracie Vaughn, who joined us. Gracie worked in my office with me. She's an MPH UNC, and really deserves a lot of the credit here because we have a very strong partnership in making sure we deliver these things to you guys. So in last year, in 2017, 2 years ago, my God, we're in 19 already. We have reached 400,000 health workers. I mean, this is kind of people that we reach. If you're interested in seeing the formula that we use for reporting on this, we'd be happy to share. But it's extremely important to us because there's a multiplier effect when you reach health workers and the workers that they reach. the workers that they train, and so forth. This is our global presence. I think it's in the white. The white color represents where IntraHealth is. Right now we fluctuate because we are such a dependent on these projects. A lot of our work comes from government. We get a lot of government grants, USAID, CDC, but we also get a substantial funding from the Bill and Melinda Gates Foundation and other West Coast foundations. So approximately we tend to, I think we are actually a little higher than this number. This is probably couple of years older, so we've been on a uptrend these days. So I think we're over 700 now, and close to 40 countries where we actually operate, and we actually have offices in close to 20 of those countries. And some of our offices are actually larger than headquarters, because some in Kenya, Senegal, Tanzania, all of those are very, very large projects with large numbers of people. A few things that we've done. The health workers that we trained in family planning, maternal and child health, and HIV/AIDS. The other one is the number of positive individuals that we provided with antiretroviral. Our HIV/AIDS portfolio is not as large as our maternal and child health, but we work in some big countries and important countries like Namibia, where there is actually hope that we might reach epidemic control. There are people who are thinking that if the trend continues, we might be able to show some very good results. In Tanzania, where we are the largest implementer of male circumcision programs. So those are some of the numbers. And then we do a lot of work in contraception, family planning. It's kind of in the DNA of IntraHealth. When we were created some 40 years ago, that's what we focused on. We focused on family planning. It's only a small part of our work today, but it's a very important part, because there are parts of the world where we still have way too low contraceptive prevalence rate. This is again, more statistics about numbers, which I need my glasses to be able to read. Children under 5 treated, antenatal care visits, people provided with nutrition counseling. Very quickly, 24 countries that are using IRIS. IRIS is our platform, our software that we've developed. We developed a suite of software to help people, countries, manage the information around the health workforce. You know, the major issue about dealing with the problem is people don't have the information. And until tools like IRIS was put out there in the market, many countries did not know. When we did this about 12 years ago in Uganda, working with the Nursing Association of Uganda, they didn't have, you should have seen the pictures, they had paper stacks like this for years and years and years, just not usable or anything. So it was when we developed our IRIS system, that's where we tested it the first. And it was with that system that they were first able to look at a map and see what the distribution of health workers were. So tools like IRIS have become extremely important, and we are proud to have the first open source software, which has now been deployed in about 24 countries. And we have close to 2 million records on health workers on that system. We have health workers and administrators who are using digital health tools, and then we have organizations who are pursuing activities that focus on gender equality. So these are all very important functions. So together we are working toward universal health care. And we do have results like this, which are very encouraging. I'm not going to read them, but you can see them. It's the beauty about UHC. It's basically we're having a global framework through which to look at our work. there are just way too many of these organizations, everybody doing their thing, but at least we have a big framework to help us look at the work. So these are some of the, and many countries have bought into this idea of having universal health care. We do focus on all of these areas, which we call solution areas, family planning and reproductive health. As I said, when IntraHealth was created, it was with the specific mandate of building capacity of individuals and institutions in sub-Saharan Africa and the Middle East at the time to increase family planning uptake. Malaria is part of what we do, HIV/AIDS, gender equality. Of course, Ebola crisis and all that have raised the attention on emerging pandemic response. Digital health is a big component. We're really doubling down on digital health because, as I said before, the world is really dreaming at reaching these objectives and continuing the progress thanks to digital. And I think because of digital health, we can really dream big. We can be in places when we've never thought about being. It really solves a lot of issues that it might not be very apparent to see, but when you think about health workers being in remote area, one of the problems that they have is really they are alone. They are lonely. They are distant from other colleagues. Well, digital health is changing a lot of that. It's giving them a lot of opportunities. One of our projects in Tanzania was all designed around trying to connect all health workers and working with the phone company and the ministry to set up this platform so that people who belong to this program can communicate themselves, etc. So digital health is a huge component. We continue to do health worker training and performance, although mostly it's technical assistance, health system strengthening, monitoring, evaluation, and then health worker policy and advocacy. Just because we feel that that's what we need to do. For the longest time, countries have just left this field to the donors and to others. They have not really taken it. It's primary health care. When you talk about primary health care, when you talk about health system, frankly, a lot of people assume that it stops at the secondary level. Basically, they say, oh, well, for primary health care, the NGOs will take care of that, or the faith-based group will take care of that. That really needs to change. You're talking about one system. In fact, you're talking about one system that really needs to have a strong foundation. If you're building a house, you start with building a very strong foundation. It should be the same with health system. We should make sure that the primary health care system, that level, is very, very strong because everything then is built on it. Anyway, so this idea that health is an investment, can't continue to re-emphasize this. We have a lot of issues related just to the fact that this is not what people believe. Many leaders in Africa and other middle-income countries, low-income countries, people will tell you that the Minister of Health is not a good negotiator when it comes to sitting around and making sure that they have their part of the budget. That's maybe why many of these countries cannot meet their target of 15%. Because the argument is health does not produce anything, it just consumes money. There is nothing further from the truth than that. It is not, and we should really get rid of that mentality because it's not true. Every single investment that we make in health actually leads to progress in other non-health sector, as a report from the ILO showed recently. that every health worker you invest in actually has the potential of creating 2.5 jobs in the non-health sectors, including agriculture, food, transportation, and think about that. Okay? So this idea really we need to continue to promote. So it's an investment because it will lead to healthy populations, it would lead to human development, and it would lead to social and economic growth. That's why time was spent by WHO, ILO, and others in really writing this big report on health investment and economic growth. It was a high-level commission that at the time was chaired by the presidents of South Africa and of France, and it really produced this wonderful report which shows the argument why we continue to promote health as an investment. In fact, poor quality health systems result in more than 9 million deaths annually in low and middle income countries, amounting to an economic welfare loss of up to 6 trillion. So this was part of that ILO report that I was talking about. So if you look at this, I hope you can see it. This is actually the Lancet's Global Health Commission on High Quality of Health System. You see that they have this big framework for high quality health system. I'm only going to focus on a little part of this because as you can see, you've got basically processes, you need processes for care, you need competent care, and you need great health systems that would lead to quality. And you have to look at the population, you have to look at governance, you have to look at the platform. So the box that we want to focus on, this one, is the health workforce. This is slightly different, but it incorporates a lot of the 6 building blocks, or what did Yamin calling them? The 6?
Yes, the WHO, I can't claim credit, the WHO system.
That's right. So focusing on the health workforce, this is the situation, unfortunately. The health workforce shortage is most pronounced in low and low income countries. And the reality, folks, we cannot achieve universal health care without having present, ready, connected, and quality health workforce in low and middle income countries. It is just, in low-income countries, as you see, the exclusion rate is just way too high. And so it is linked. It is linked to the density of the health workforce. This is another slide that shows the divide between rural and urban. And you will see that this is true in all regions of the world. It's more pronounced in Africa and the Middle East, where the bar tend to be higher. But it is true that where you have disparities, those that live in urban setting tend to at least have more opportunities for healthcare than those who live in rural. Now, it is said that the majority of the planet now lives in urban area. So there are a lot of people who are making the case that we need to pay attention to urbanization. Because you can tackle a lot of these problems through urbanization, and people who look at the world through the lens of urbanization do have a lot of opportunity for especially integrated approach, which I think is something the health field needs as well. So it is a crisis, and unfortunately, a looming shortage of 18 million skilled workers in low and income countries stand between us and the promise of universal health care and the economies it could help stimulate. So what do we do about that? Because that is really the situation. And it's almost like our hands are tied or something, or sometimes the message is, well, we just have to do with it, and etc. I don't know, but it is pretty serious, and what might ask, what are we going to do to really pay attention to this problem? On one hand, it is true that we cannot just wait for a number of doctors to be trained or a number of midwives to be trained, so we have to do something, which is why actually there's this promotion of task shifting, of maybe doing some other things. Maybe the focus is not quite right. Maybe Africa does not need to take 6 years to train its doctors. Maybe there are categories of doctors that we can train. A lot of these things. What are you going to do about the big, about the brain drain? What are you going to do about people trying to look at greener pastures? You know, these are huge, huge issues. They are not simple. When WHO and the Global Health Workforce Alliance were looking at this, they thought about this code of conduct, you know, which exists. A lot of countries have signed. This country has never signed that, by the way. But it's not a binding thing anyway. And then what are you going to do? People talk about repair. People talk about the moral dilemma of, you know, a country like Malawi spends its meager resources on trying to train Malawian, and then they are very proud to migrate to the UK and work in the UK. So what do we do with that? Why a lot of people are proposing this labor market approach, to just say that you have to take it just like any other field. People are going to go where they can make more money, where they can have a better life, where they can have better opportunities, and so forth. But nevertheless, it's a severe shortage, and we will need to address it very rapidly. I do want to give us a little bit more time to chat. These might be a little bit hard to read, but it's, again, you've probably seen some of these. It's the global disease burden by region. I think you've heard that statistics that Africa has the highest burden of disease and the lowest number of health workers. Unfortunately, that is the case. It is shifting. We are. You know, we need to respond and anticipate to this shift when training and planning. It is shifting along with everything else that is shifting in this field. You know that in terms of public health, it's a big shift with non-communicable diseases as well. So, you know, our health system are not going to be just guided by the task of eliminating HIV/AIDS, malaria, and so forth. We do have to live with these new diseases that in fact are bigger killers than any other one of these individual diseases. So it's, there are definitely a lot of implications. Some of them are summarized here for you. These are some practical implications of the crisis. So the WHO has deemed that 20 of these countries in the world with the highest child mortality rate are also countries where the health workforce are crisis countries. PEPFAR indicated that 14 of its focus countries all cite a lack of adequate staff and staff turnover as the major problem for adequate HIV/AIDS care. Only 4 of the 73 countries that comprise the 96% of maternal death have adequate midwives. And then prior to 15, the Ebola epidemic in West Africa, the countries of Guinea and Liberia, Sierra Leone, which were very, very much touched. And these countries, when we studied them, are just the poorest in terms of available health workers. So I was mentioning earlier about this recent report. I just wanted to put it there. Maybe you guys have already seen this. The WHO released a groundbreaking publication on global health workforce, which is really focused on working for health and growth. So if you have not, I'd encourage you to look at it. because it really has some very, very powerful statistics and very good content for developing good advocacy package. I would also invite you to look at the global strategy for human resources for health. Gavin mentioned it earlier in the introduction. We are actually proud and happy that the world actually has a global strategy. This is not, we've been talking a lot about this, so it was good that they finally came up with this strategy. I hope you can read it. This basically talk about what we need to do to expand human resources for health. The lower end of the arrow, you have necessary concerted tripartite social dialogue that need to exist. This is not going to be solved just by the public sector or government. It's way too big a task. The whole idea of healthcare only being handled by the public sector is just not realistic. Unless everybody plays their part, which means the private sector, which means civil society, it's just too much of a burden. So I think the first activity is just kind of sharing in that burden, and everybody needs to do their part. So while people are discussing whether the private sector should be involved in this, it is really a false problem, in my opinion, because there are so many resources that exist in the private sector, we know dwarf what exists in humanitarian assistance and so forth. So it is clear that having that sector do its part is an integral part of the strategy that's going to help us deal with this. If we had more opening to do things like outsourcing, where the private sector, you know, both countries that we work in, both Kenya and Nigeria, are countries where people are so entrepreneurial. They can't wait to do their part. They just need an enabling environment. So really, this idea needs to be promoted again, that we really need all parts in this equation. We do need health labor market data. In talking to some colleagues this week, she was under the impression that actually we're not giving this enough attention. We talk about it, but both the World Bank and WHO are not doing enough. But I think we need to promote more. I think we would get a lot more understanding and appreciation if more people were trained in these notions of labor market and why it's important to really do their planning for health with that in mind. Otherwise, a lot of people are very disappointed, and you know, because they've made a lot of investment to only see that disappear, and people live with it. We do need enhanced medical workforce, national workforce strategy. There is something called the National Health Workforce Account, which the new strategy is proposing, that the countries should just focus on developing these accounts, getting the right information, getting the right data, and beginning to really make some serious commitments, domestic resource mobilization. I know there's a lot of demand for those, but unless we have more involvement from national governments, it's going to be difficult. Anyway, the last part of that is transformational education, which is a big part because we need to look at, not just having a pipeline, a decent pipeline of health workers who you know are going to enter the system, but we need to look at the entire way we train these health workers, because currently there's a mismatch between how we train them and the reality. I think it's getting better, but we're not totally there. A lot of countries in Africa inherited from the old colonial powers, and then most of Africa, it's still those systems that are in force. So something needs to be done about that. And we've got some good examples about things being done in South Africa and so forth, but we need a lot more work. We do need health work. We need to invest in data and national health work strategies. national health workforce accounts. If people have the data, then they can start to do something about it. But without the data, they just can't. The problem is we have to do a lot more than just develop tools to collect the data. We have way too many tools to collect data. You've been hearing about this pilotitis syndrome. Everybody is piloting a new way, a new gadget, a new way to collect data. What we're not really doing yet is using that data, utilizing that data. I was happy to see that there are more actors actually getting into this. Bill and Melinda Gates are very committed to this field. As you know, Melinda Gates started a new initiative 2 years ago. It decided to spend $80 million just for to promote data, collecting data, especially around gender. But we need a lot more. This week, a colleague of mine and I spoke to the Cloudera Foundation, which is Cloudera is the big data firm, and they are looking to support organizations to do a better job at the data. So anybody working in this field needs to continue to pay very much attention to this. Is that a video you wanted me to play there?
It's about 3 minutes, depending on time.
Right after I shift. Oh.
Do we want to play a video?
Yeah.
Okay. Sorry. Hold on, everyone.
So 3 minutes. You promise.
Yeah, I promise. But you can skip it if you'd like for conversation.
No, that's okay.
Make sure the sound works. Nope. All right.
Yeah.
Just going to have to mess around with the volume and
I teach in this class, so
yeah, thanks.
my TAs have taught me where it is.
Please, yes, please.
Well, we'll see if my TAs have taught me whether I've learned. It's down here, it's this one. Yeah. I know. Hold on. Yeah.
It's going.
Is there any volume?
All right, everyone.
Yeah.
Thanks so much for your patience. While how many people, any more PhDs? How many, or MDs, how many MDs does it take to figure out that?
It's on top volume. It's top volume and it's unmuted. I don't know what more to...
Well,
you can see
we can circulate it after the lecture
Sure,
to
we
the
can.
group.
What a great idea.
Yes.
Yes. Do that. We will add
Yes, this will be available to
We will
you.
add it online to the
Yeah.
to the DGHI website where this event lives. We'll
Sounds
on
good.
Okay.
Sounds good.
Thanks. Great way to
Yes, yes.
overcome.
So just a couple more slides here. 91% of health employment potential exists in low-income countries. Again, inclusive economic growth. This whole idea of full employment. You need to look at just not any kind of jobs, because the other thing we've found in our studies is a lot of the we're talking about quality jobs, good jobs, decent jobs, full employment. There are just way too many still volunteerism in this field. Whether you start looking at community health workers, you're looking at other lay workers contributing. We just have so many people volunteering their time. You cannot have a system that is sustainable. That we need to translate this into real employment. That statistic I already covered. Each new job in the health sector can result in 2.3. The whole idea of transformative education, again, think about the things you can do to encourage people to embrace the health field. I like to say that every time I have an opportunity. Talk to your brothers, sisters, your cousins, your relatives, encourage them to embrace this field, because it's a very useful and important field. If we put primary and secondary education within reach of more children, we can augment the future pool. We can definitely positively impact the future pool of health worker candidates. So it's really begin to see the relationship with other adjacent sectors, like the education sector. We do need to reform pre-service education and employ task shifting to address disease burden. We need to focus on primary health care. We haven't done that. We are kind of trying to do catch-up work. And when we talk about universal health care, we said, oh my God, universal meaning everybody and meaning in priority people in the last mile. That somebody told me actually we should be calling the first mile to emphasize our attention to them. Makes it not kind of the afterthought that the idea of a last mile conjure. And we need to optimize the mix of skills within the health workforce, promote this whole idea of team and so forth. To end here, I just wanted to share a good example. It's a very uplifting example. We like to share it. In Kenya, one of the strategies we have is to see how we can influence people entering school. So we actually devised this. We work with something called the Afya Elimu Fund. It's an educational fund to provide loans. And in this particular case in Kenya, we target people coming from low-income areas, poor areas, remote areas. So the highest rate of youth employment in Kenya and a severe shortage of health workers. And so when we started this, we actually attracted a lot of private sector. USAID made some investment in this, and people can pay very low rates on these loans, and they're not asking for any other privilege except for a chance. And we have the story of so this is what it does. It provides affordable loan to health professionals. Launched in 2013, and it has provided low interest, probably by now over 20,000 students who are enrolled in 99. So these kind of things, I think we need to see more of this type of activity. They're not just handouts and loans, but it's just giving a chance for people to actually invest in. So this is an example of us. We're all proud of Osoro, who is a doctor who benefited from these loans. He's now working to repay his loan at 4% interest rate. And he actually set up his little clinic. And he now employs 5 other health workers, and he serves about 40 clients per day. And there are thousands and thousands of examples like this, where people are just needing a little push, a little help. These are just some statistic on Kenya, and our call to action, coming back to that SDG 3 that Gavin introduced at the beginning. Just a reminder, it's about substantially increasing health financing and recruitment, developing training and retention of the health workforce, especially in least developed countries. So doing these actions will definitely lead to us making faster progress. So that is what I wanted to present, just to hopefully to open the thing. We have a few more minutes that we can spend on answering questions and talking more about the work of IntraHealth, which you can always access by contacting me or Gracie or anybody, any one of our colleagues. So thank you very much.
Thank you.
Thank you. My name is Prabodh Chanda. So I lived in Africa and worked for Harvard School of Public Health in Botswana toward the same intervention or same efforts that the IntraHealth is doing. It's not my question, it's just a comment. Basically, I have seen personally that when the HIV/AIDS epidemic in Botswana, in Africa in particular, that more than 40% kids were dying or were born with the HIV disease. You know?
Yes.
So really, the great effort from all the institutions like
Yes.
yours has made a big impact. And now the mortality rate has reduced to less than 5%. You know, so it's a great work done by all these organizations. You know.
And Botswana is actually a very, they've been doing a great job. They've been doing a great job. Of those countries, by the way, it is one of those countries that have reached 15% of investment.
Yes.
Yeah.
They recognize the importance of that.
Yeah.
So it's a little bit worrying that when you mention that many countries are not contributing 15%, you know.
They're not.
And they're not recognizing what they are losing, you know.
They're not. It's a big problem. You know, what do? You can't, people have so many priorities. You know, they'll tell you, where do I start? I'd rather invest in education. I'd rather invest in food security.
Yeah.
In a lot of ways, when you're dealing with somebody who's struggling to go through the day, you can understand that their priorities are just such that, what are they going to do? If they have $1 in their pocket, what do you think they're going to spend it on? Yeah.
Just as a follow-up to that, by the way, my name is Yohan. I'm a second-year master's student from Cameroon, very interested in health systems, so this was very relevant. But following up on that, with the example that you mentioned, you know, there's so many priorities. I think on the individual level, it can be hard, you know, if you're low income, it can be hard, you know, prioritizing health over other things. But I'm wondering, how's the dialogue? You mentioned that one of the steps in terms of improving the health resource situation, it's that dialogue that needs to start. And I'm wondering, are the health ministers and the ministers of finance, do you see that dialogue happening? Because I think at that level, you know, they're thinking about priorities for the country, not for like their own individual homes.
Absolutely.
And so I'm wondering, are they, you know, are the ministers of health now reframing this issue as, oh, if we want to improve, you know, other things, you know, we need to take into consideration health. So I'm wondering how that dialogue is going on.
I'm hoping that that's gonna. I mean, I was reading. So there was some direct summary on this African Union meeting, and I'm happy with seeing people like President Kagame step up and begin that conversation. What I think is happening is that because that thing was, again, another top-down thing, we have this gathering periodically, the spring meeting at the World Bank, they started bringing ministers of health and finance together. But I think what we need to do is really for people to take initiatives in the field. I think if you see examples of countries who are doing it, and frankly, if you visit Rwanda and Ethiopia, you're beginning to see actions of the government when they really take control and they take the lead and they tell the donors what they want. That's what we need. But in the majority of cases, it's not like that. It's the thinking is done in New York or Geneva or someplace. It takes forever for that conversation to translate into real reality in the countries. And what we need is just more actions from the bottom. So there are a few countries where it's beginning to happen. I think the openness to private sector, for example, I think we are seeing more and more. We still have lots of resistance. So we're just scratching the surface.
Resistance from whom? You mentioned there's still a lot of resistance.
Well, there are resistance because everything is super politicized. And then the problem, in fact, the biggest threat we have in health is very easily kidnapped by politicians. Why do you think people neglect primary health care? Because everybody wants to construct a huge, big hospital and have their name on it. Because it's very concrete. You can say, I've done this, I've built this hospital, you know. Yeah, everybody is running with universal health care. Some countries are actually very strong statement. So there's that part. There's the part, it's political. It's also power. It's people control things, they wanna, so they do. But I think the biggest threat is just, it's politicizing this. Yeah.
Thanks for your talk. It was really interesting. I used to work on that Human Resources for Health 2030 program run by Chemonics.
The one they took from us.
Yeah. I started a little bit actually, but okay. A lot of what you said in terms of the kind of pilotitis of tools really resonated with, I think, some of the way not just HRH 2030 was working, but lots of cooperative agreements and contracts of similar type. And I guess my question is, following what you just shared, yes, ground up, I agree, ground up interventions and movement is really important, but in terms of the way that donors shape the things that they want, the tools that they're asking for, what do you think can change or should change on that level?
Yeah. Well, I think you have to be realistic, and I think trying to change the way donors change is, I'm not sure how realistic it is. I think donors are going to do what moves them. I think they're going to invest according to their own interest and so forth. I don't think that's going to change. I think the onus is going to be on implementing organization, although it can be very difficult. If you worked with USAID and you win one of their grants, then your hands are tied, and you have to do what they... But I think it's for us, we are in the best position to sort of be flexible, because it's all about adapting to the realities in the field. But, Bill and Melinda Gates are trying to change the way they do business. They are approaching countries. In Nigeria, for example, they are looking at it very differently. They are now going to the government and saying, I want to support the work of the government. What is it that you're doing? Show me your plan and stuff, and I'm going to try to align. That's not typically how they do it. They come in, they have some ideas, they do a proof of concept, they fund that, and they might show that it works very well, but they might say, okay, you can find some other fund to do it. Or it's not working, we're going to try something else different. It's really different. What are you going to do with PEPFAR that decides when they come to our country, they're going to use a scientific approach to this. They're going to go to sites where there is a high concentration of HIV/AIDS positive people, because that's what they want to do. We don't care about all of your plan or what you were going to do X, Y, Z. Now we're going to do, and since you're getting our money, you're going to do what we want you to do. This is why we're dealing with a not level playing field. And I think that's going to change, but that's going to take some time. So it's complicated, isn't it?
Can I just do a follow-up on that?
Sure.
Yeah. So I work, as I mentioned, in Botswana, and I was working for many other countries, Tanzania, Zambia, and Zimbabwe, to get them the CDC and the NIH and PEPFAR grant. So after a few years, the donors were using the term donors fatigue. So they were tired, means they were not seeing the impact.
That's right.
So they were tired of giving every year.
That's
and
right.
As you rightly mentioned about the data impact.
Yep.
So many countries cannot show, as you also rightly mentioned, that data is being collected, but it's not being showcased to the donor countries to show them how much needle they have moved. So that's donor fatigue, and with the lack of the data, it's causing all this, And other worrying part is that all the CDC and PEPFAR, the grant is diminishing every day.
It is. It is.
And so I see a further challenge on.
So it's actually important that you say that. There is definitely a movement to want to make things more local, right? Well, the donors, in fact, they want to cut so that's why organizations like us have to really look at the writing is on the wall. Everybody's trying to find a way to go directly to the countries. So they want to fund. What is lacking usually, it's the capacity to manage the funds. right? Current governments just don't have it. A lot of these local institutions don't have it. That's why we're still in existence, because at least we understand that the person. But there's true commitment, it looks like. PEPFAR has now announced that they're going to go with this 70-30 rule. They want 70% of their resources in I don't know how many years to go to local organizations. And as a matter of fact, the new project was just created, which we actually have a chance of winning, which is called ASAP, which is designed to support local organizations and build their capacity to be able to accept money. Bill and Melinda Gates are doing the same thing. They're thinking more and more. Bill Gates is saying development is not going to be achieved by people flying in and out of Africa or some other places. We need more homegrown, underground systems. So I think that means that all of us have to put our hat of capacity builders. You know, starting from where you are as a student when you're working. You know, how can you bring along colleague students in the country? What can you do? How are you going to make sure that whatever you do has a component of helping train someone else, et cetera. Yes, I think we're probably going to be the last one.
The last one.
Yes.
Do you have the final word?
Yes.
No pressure. Making a good question.
I guess it kind of links into what we were saying, and you were talking about how primary healthcare is probably the first building block in strengthening the health system. But then you also talk, about all these actors that are involved. And for example, in the field of digital health, like how do you reconcile all these different actors who have like different initiatives that are started in different partnerships? How does that work in the end to construct this primary healthcare system?
Yeah,
it's not
I think it makes it more difficult, but I think it makes it more exciting too. I think this idea that global health is everybody's business, I think is actually very powerful. You have to be ready for the consequences, which means, you take the social entrepreneurs, you guys can relate to that. The social entrepreneurs have entered this space in big numbers, big time. And social entrepreneurs, if you're one, you think that you can do it faster, cheaper, better, and then basically you're beginning to look at organizations like us as dinosaurs. But I was serving on the board of Interaction, which is the association of nonprofit in the US, about 300 members. In that group, it was taking them a long time to accept that this field is changing. We now have new players that entered the field, etc. So you have to make room, and then we have to change our vision of what development is and how it's conducted. There's not going to be one size fits all, and there's not going to be one way of doing this. As you get down to the decentralized level, everything then is contextual. It's really about the context. But you raise a very important point, which is, when are we part of the problem? When are there just too many players? And I don't know. I don't know how to handle that. But the other side of it is that it's very exciting, and it's new energy, and it's more energy in our field. So you have to learn to kind of deal with that.
I feel like we could talk all afternoon.
Yes.
We're so lucky to have you. Thank you so much.